So when a patient's kidneys suddenly fail, we usually think about two things, right? Is there a problem with blood flow getting to the kidneys, or is there some kind of blockage stopping urine from getting out? But what happens when the problem is actually happening inside the kidney itself? Well, that's what we're talking about today. It's called intrarenal AKI, and it's a direct hit on the kidney's own machinery.
All right, here's our game plan for this explainer. We're going to kick things off with a solid definition of intrarenal AKI. Then we'll get into the 4 major things that cause it. After that, we'll zoom way in to see what's happening inside a damaged nephron, talk about how to spot it clinically, and finally, we'll cover how to manage it.
Okay, first things first, we have to put this in context. You know that acute kidney injury, or AKI, has 3 main categories. There's prerenal, which is any problem before the kidney. There's postrenal, which is any problem after the kidney. And then there's our topic for today, intrarenal, where the damage is happening right there within the kidney tissue itself.
So this is the key point. We're not talking about a lack of blood supply or a blocked ureter. The actual problem, the damage, is happening to the kidney's own working parts, what we call the parenchyma. This means the glomeruli, the tubules, all that important tissue is taking a direct hit.
So now that we know where the problem is, the next big question is, what's causing it? Turns out we can group the causes of intrarenal AKI into 4 main categories.
This table lays it out perfectly. You can have issues with the tubules, the interstitium, the glomeruli, or the blood vessels. But listen, the one you're going to see most often by a long shot is acute tubular necrosis, or ATN. And this is usually caused by one of 2 things, either ischemia, meaning the tubules aren't getting enough oxygen, or nephrotoxins, direct poisoning from things like certain medications or even IV contrast dye. To really understand how this all goes down, we've got to zoom in. Let's get to the microscopic level of the nephron and watch the chain reaction that happens, especially in a classic case of ATN.
So check this out. It's a cascade effect. It starts with an injury to the cells lining the tubules. Then, these dead cells break off and basically clog up the works, creating an obstruction. To make matters worse, the damaged tubule wall starts to leak, so the filtrate that's supposed to become urine leaks back into the body. It's this 1-2 punch of a blockage and a leak that causes the GFR to just plummet.
Okay, so with all that chaos happening inside the kidney, what does the patient actually look like? What are the signs we need to look for, and how do we confirm our diagnosis? Let's dive into the clues.
The clinical picture makes total sense when you think about the pathology. The kidneys aren't filtering, so the patient often isn't making much urine. That's oliguria. All that extra fluid backs up, causing swelling and high blood pressure. And because the waste products aren't getting cleared, they build up in the blood, making the patient feel nauseous, weak, and just plain awful. Now for the diagnosis, we're looking at both blood and urine. The blood tests will show high creatinine and urea, which tells us the kidneys are failing. But the real story is in the urine. We're looking for things called casts, which are basically little molds of the inside of the tubules. If you find muddy brown or granular casts, that's a huge clue for acute tubular necrosis. On the other hand, if you see red blood cell casts, that suggests the problem is in the glomerulus instead. And this number is another massive clue, the fractional excretion of sodium, or FNA. See, a healthy kidney is really good at reabsorbing sodium, but in intrinsic AKI, the damaged tubules just can't do their job. They start wasting sodium into the urine. So if more than 2% of the sodium the kidney filters is ending up in the urine, it's a really strong sign that damage is happening inside the kidney itself.
Okay, so once we've nailed the diagnosis, it's time to act. There's no single magic cure here. Instead, management is all about a supportive strategy to give the kidneys the best possible chance to heal. The management approach is pretty straightforward. First, you have to get rid of the cause. Stop any offending drugs, treat any infections. Second, you provide support. This means you're carefully managing fluids and electrolytes, watching that potassium level like a hawk. And third, if things get really severe, we're talking dangerous complications. You have to initiate dialysis to temporarily do the kidney's job for them.
So let's wrap this up with the absolute key takeaways. Intrarenal AKI is direct damage happening inside the kidney. The number 1 cause is ATN from either ischemia or toxins. Your biggest diagnostic clues are going to be in the urine. Look for those casts and check the FNA. And finally, management is all about removing the cause and providing top-notch supportive care. And I'll leave you with a final thought to piece it all together. We've seen that looking at urine under a microscope is almost like doing a liquid biopsy of the kidney. So if granular casts mean tubular injury and RBC casts mean glomerular injury, what would finding white blood cell casts suggest? Well, since white blood cells fight inflammation and infection, that would point you straight towards an inflammatory cause like acute interstitial nephritis. Understanding these clues is really what makes diagnosing intrarenal AKI so interesting.